safety pin. So presenting Mr. J, a 33-year-old gentleman who presented with 3 months history of high-grade fever, which is associated with chills, and migratory joint pains, which is asymmetrical, involving the left hip, knee, and ankle joints. There was associated signs of inflammation like swelling, redness, restricted motion, range of motion, and also pain, which is more in the morning and gets relieved by the end of the day. But there is no history of any paresthesia, myelopathy, radiculopathy. There's no GI symptoms, and there's no symptom suggestive of any connective tissue disorder. He gives a history of high-risk behavior, and he also gives history of multiple blood transfusions from outside, but we do not have the reports of the same. There is no history of any loss of weight and no other comorbidities present. There is no significant family history. On examination, his vitals at the time of admission were stable and he was febrile with a temperature of 100.6. There was no pallor, erythrocyanosis, clubbing, lymphadenopathy, or edema. There are no nail or skin changes noted, no subcutaneous nodules present. There are no features of infective endocarditis like sphincter hemorrhages, osseous nodes, and ganglia lesions. Local examination, he has all the signs of inflammation on the joints. And systemic examination wise, he has splenomegaly on palpation, and genital examination was normal. Now summarizing, a 33-year-old gentleman with multiple blood transfusions from outside has presented to us with 3 months history of fever with joint pains, which is migratory type of joint pains. So what are the differentials that we are considered when we first saw this patient was, initially we have considered the possibility of infective arthritis, mostly bacterial like staphylococcus. We have also considered possibility of gonococcal because of his high-risk behavior. And because of chronic history and because we are from tropical climate, we have also considered possibility of tuberculosis. We did consider possibility of infective endocarditis based on the history and rheumatic fever. And reactive arthritis like SPA, we also consider possibility of SPA because there is more axial joint involvement more than rheumatoid arthritis, which usually involves the small joints. And on the bottom of the list, we also did keep an our differentials of connective tissue disorders, psoriatic arthritis, and IBD, though he didn't have features of any GI symptoms or any nail or skin changes, and no connective tissue disorders, and he's also male. So our initial investigation showed that he's anemic with HB of 5.7. His total counts were 10,000 with a slight mild thrombocytopenia. He has no AKI. He has mild acidosis present, and LFT shows an elevated alkaline phosphatase present with an elevated GGT indicating as bone inflammation. His blood-borne virus screening was negative. We have evaluated on the anemia part, which looks like an iron deficiency anemia. Because there is mild thrombocytopenia, we have also done a bone marrow which showed myeloid hyperplasia with left shift and toxic changes indicating an infection. So CRP and ESR are both elevated, indicating an infective or inflammatory etiology. We have done investigations to rule out other organisms like Brucella, rheumatoid arthritis, and we have also ruled out post-streptococcal joint pains. We have ruled out connective tissue disorder, ANA was negative. We have done an echo which didn't show any vegetations, and ultrasound was done because of the splenomegaly, which shows splenomegaly with multiple hypoechoic foci. X-ray was done, which was normal. Synovial fluid analysis shows elevated counts, which are neutrophilic predominant, and expert is negative. So first, I would like to brush up a little bit on polyarthritis and what are the causes of polyarthritis. Now, as we already know, polyarthritis means there is inflammation. There's inflammation in at least 5 joints, and we can broadly classify polyarthritis based on age, duration, and type of affected joints, type of environment, and clinical pattern. It can be young or adults. When compared to elderly people, we usually consider crystal arthropathies. Duration, acute or chronic. Acute is less than 6 weeks, chronic is more than 6 weeks. And can be large or small joint involvement, can be symmetric or asymmetric, and migratory, or it can be additive, like where one joint will be involved followed by another joint and another joint, or it can be intermittent, where we have joint pains followed by relieving symptoms and again joint pains. So based on it, we can classify the causes of polyarthritis into infective, post-infective, or reactive. rheumatoid, and other causes. Now, infective causes again can be viral, bacterial, and fungal. So in our patients, we didn't consider the viral causes because viral causes are usually acute in nature. So, but persistent bacterial infections can be present. So we have considered the bacterial infections and mycobacterial infections, but both of them are negative. We have also considered possibility of post streptococcal infections. That's why we have done an ASO, which was negative. He didn't have any GI symptoms, so we have not considered the Salmonella, Campylobacter. We didn't consider IBD or retouch because he didn't have any urogenital involvement. We did consider infective endocarditis. However, echo was normal and he didn't have any peripheral signs. Other inflammatory rheumatoid conditions that were considered that can cause polyarthritis are rheumatoid arthritis and psoriatic arthritis, crystal arthropathies, and SLEs, in which we have considered the possibility of SPA, but other conditions are much unlikely. And other causes like solid organ tumors, hematological malignancies, sarcoidosis, and drugs can also lead to polyarthritis. Now, in our patient, our blood culture, however, grew Burkholderia pseudomallei. Now, as we all know, Burkholderia pseudomallei is a gram-negative bacterium which is commonly found in the environment, and it causes something known as melioidosis or Whitmore's disease. And why is it called as Whitmore's disease? Is because it was first identified and cultured by, and he has named it as Bacillus pseudomallei. It is predominantly seen in tropical and subtropical climates. That's why it's most commonly seen in Southeast Asia. So it can be grown on ash down selective medium, where you can see that it has a crystal violet colored appearance, and gram staining shows a safety pin appearance. Like you can see, this is the distribution of Burkholderia, which shows that in Southeast countries, especially India, Singapore, Thailand, are much more predominant. Now, what is the main mode of transmission is by a percutaneous inoculation. When a person walks in a wet soil, or if there are any floods, or in such conditions, patients can get exposed to wet soils from which the bacterium can enter the human body. And the most common risk factor is diabetes. We do not usually see, it is rare to see melioidosis in a healthy individual, but in case of risk factors like diabetes, or if they have any alcohol use, chronic kidney disease, chronic lung disease, they can usually have increased risk factor to melioidosis. And in children, they are majorly associated with thalassemia also. However, it's very rare in adults. So if you can see, melioidosis has a multiple spectrum of involvement. It can involve the head and neck, respiratory system. It can involve cardiovascular system, genital system, musculoskeletal system, out of which the most common one is the respiratory system, where it can cause pneumonia and later can cause lung abscess. And you can also see that here in the graph that the most common cause is pneumonia, but however, we can also see other cases also. So how do we treat melioidosis? Melioidosis, we have an intensive phase therapy and an eradication phase therapy. And our drug of choice is usually ceftazimide. We can also give meropenem. And the duration will depend upon the involvement of melioidosis. It is for any intensive phase, minimum we should give it for 2 weeks. And if there is any neurological involvement, we can actually give it for 3 months also. And we can also add Septran, which is a Septran for in case if there is a neurological involvement or osteomyelitis or septic arthritis. And we also have to give Septran during eradication phase, and which minimum should be for 3 months. However, it can extend up to 8 to 9 months also. So this is roughly showing how each involvement can the duration for how long we'll give the medications. In case of pneumonia, we'll give for 2 weeks and 3 months. In case of osteomyelitis, for 6 weeks and 6 months. Similar to septic arthritis, we usually give for 6 weeks and eradication phase for 6 months. So in our patient, he was started on ceftazimide and Septran, and he was intensive phase was planned for 4 to 6 weeks. However, our patient is a 33-year-old gentleman who didn't have any complication, no comorbidities, no diabetes, no bloodborne virus, no chronic kidney disease. So why did he develop amyloidosis? So one thing that we have found is why is it in children that thalassemia has an increased risk for amyloidosis. The reason is not the disease as such, but it is because of the excess iron following blood transfusion. So excess iron will cause production of reactive oxygen species, which will cause alteration in the neutrophils, which will therefore uh, cause dysfunction of neutrophils. And once there is neutrophilic dysfunction, the immunity would be less. There will be increased risk for amyloidosis. And also, iron is important for bacterial growth. And it is shown that Burkholderia pseudomallei does produce some sideropores, which will be able which will help to extract iron from the surroundings. So, because he had history of multiple blood transfusions from outside, we are considering the possibility that his excess iron is causing his, is increasing his risk for amyloidosis. So, what learning points from this presentation is what are the spectrum of diseases that we'll see in Burkholderia, and for how long we'll give the treatment.
Thanks, Sharon. Just a couple of questions. What is ceftazimide? Is ceftazidime?
Ceftazidime.
Okay. You said ceftazimide. I thought I missed some new antibiotic. I thought so. That's ceftazidime. Second thing is, what is the mechanism for the polyarthritis? Is it just like an immune reaction? Because did the synovial fluid grow Burkholderia?
By the time he could take synovial fluid, we have already started him on antibiotics, but then there is an increased WBC count present.
How long was he on antibiotics before you did the synovial fluid?
I'm not sure.
Sure. Because there are only 6,000 cells, no?
6,000.
And 60% neutrophils.
Yes, sir.
So what is the mechanism you thought? You thought it's the Burkholderia is causing the polyarthritis, huh?
Yes. Because 2 out of 3 blood cultures grew Burkholderia.
Yeah, no, he has Burkholderia. There's no debate on that. And but what caused the polyarthritis is
other causes have already.
Uric acid was normal.
Uric acid is normal.
Uric acid was normal.
Other causes also we have ruled out, like Drusilla, other infective causes, inflammatory causes have been ruled out.
And this gentleman is okay now?
Yeah, with the starting of antibiotics, his fevers have.
He's still in the hospital or he's gone home?
He's planned for discharge.
And his joint pains also have settled?
Has settled.
Has settled. Okay. Yeah.
So as of now, no. We have done an MRI of the joint to see if there is any requirement. It's still awaited.
He has a polyarthritis, no?
Yes.
You think all the joints are affected by Burkholderia? I'm not so sure whether it's really a osteomyelitis itself or an arthritis. Actually, it's not osteomyelitis, it's arthritis, the joints. So you're saying joints. Order? Yeah.
In these cases, when we give antibiotic duration, we should be very careful because incomplete antibiotic therapy will cause repeat infection. So the intensive phase actually starts from the first negative culture. It doesn't start from the beginning of the antibiotic therapy, but from the negative culture. That we should be very careful when we are counting the.
We have not yet taken a repeat blood culture to see if there is clearance. And after that only we'll plan for further. If there is no improvement, we are planning to do a washout.
Most of the meanwhile patients require source control with the washout. Otherwise, they keep feeding in different joints. We require washout.
He has he has a polyarthritis, no?
Yes, sir.
Multiple, all large and small joint.
No, only large joints involving the knee, hip, and
knee.
ankle.
Okay. That synovial analysis was the knee joint. Huh? That
yes,
knee joint. It's a bit strange. Yeah.